Assalamualaikum and good afternoon. Thank you, Dr. Muslidah. We come to the second last topics for our symposium. So I'm talking about the palliative care issue in cervical cancer. So as what we know, that is up to now we're still dealing with the late stage diagnosis of cervical cancer in about 80% of cases. Therefore, palliative care remains a very important issue here. And then palliative care doesn't mean that doing nothing, but it is aimed to improve quality of life by managing the symptoms produced by ongoing tumor growth. So among the important palliative care issue is, number one is the cancer pain. We will talk about in great length about cancer pain. The others like the tumor bleeding, tumor infection, malignant fistula. I will not touch on fistula because our guest speaker, Mr. Wan Kamiza, is here to talk about it. And then other urology complications such as obstructive bronchitis, nutrition problems, Lymphoedema, and Venous thromboembolism. So we go to the first one, is the cancer pain. If we look at the systematic review on the symptom prevalence, it is almost the 71%. Cancer pain is the second most common symptom, with a true prevalence about 71%. And then over 1/3 of cancer pain patients experience moderate to severe pain, with a pain score of about more than 4 over 10. And then what about the Malaysian situation? In a study done by the Prof. Mazidah Mansur from the UNMC, 89% of patients with advanced cancer have pain, and then almost 50% of them reported moderate to severe cancer pain with a pain score more than 4, and then 7% of them reported more than one source of pain. So, however, although the pain is a significant source of distress, if you look at the European data, almost 43% of them remain untreated. Then what about our local situation? If you look at the one paper from Richard Lin, it was estimated in our country is less than 20% of cancer pain experiencing moderate to severe cancer pain receive opioid analgesia. And because of that, I think everybody is aware that in Ministry of Health Hospital in 2008, we start using the pain as a fifth vital sign. Then, basically, principle of cancer pain management start with comprehensive pain assessment. Basically, to determine the nature and pathophysiology of pain, and determine the severity of pain, and then determine the impact of pain to the function and quality of life. Therefore, we can determine the response to the intervention. And then after we treat the patient, we reassess pain and treatment effectiveness and adjust the treatment strategy if it is indicated. And then often we need to interprofessional collaboration in multidisciplinary teams. And we need to involve both patient and their family, or the one who take care of them. And we need to adhere to the management guideline. Then we go back to the little bit of basics about pathophysiology classification of cancer pain. Then one, we have pain that produced due to the tumor infiltration in the tissue resulting in tissue damage. That is called nociceptive pain. And then if the tissue is a visceral tissue, we call visceral pain, and then if it is a peripheral tissue, somatic pain. Then another type of pain which is more difficult to control is a pain as a result of abnormal somatosensory processing. If it is a tumor infiltrate into the nervous system, then this pain will be presented with burning, pricking, or some patients describe as electric light pain or shooting pain. Sometimes a deep aching component. Then we follow the World Health Organization recommendation. The basic principle of pharmacological treatment is by the mouth, by the cloth, and by the ladder. What does it mean is the route of administration as far as possible is oral unless patient cannot take orally, or the dosing of analgesic should be a regular dose, not on PRN basis. And the choice of analgesic should be guided by the World Health Organization analgesic ladder. So this is the our new clinical practice guideline on cancer pain, which is this adapted. This analgesic ladder is adapted from the World Health Organization. And then we have the first steps in the non-opioid analgesic. Is called, among them is a familiar medication, paracetamol, non-steroidal anti-inflammatory drugs, and also COX-2 inhibitor. The second step, the step 2, is a weak opioid, which is the drug is common to us, is tramadol, codeine, dihydrocodeine, and then sometimes we do also have the combination of two. For example, Adjuvant. Adjuvant is a combination of paracetamol and tramadol, which is available in the market right now. And then often, if the pain is becoming more severe and difficult to control, we have to resort to the strong opioid. All these three strong opioids available in Malaysia is morphine, oxycodone, and also fentanyl. In Malaysia, we talk about strong opioid analgesic because we know there is about half of the patients eventually will develop severe pain, cannot be controlled by the step 1 and step 2 analgesic ladder. They require the strong opioid. So in Malaysia, we have the morphine, fentanyl, and also oxycodone. All of them is available in the Malaysian market, and all of them is also available in the Ministry of Health logo. And then side effect to all these opioid, drowsiness, constipation, nausea, vomiting, pruritus. This is a common side effect. And then we need to aware that there is no maximum dose for strong opioid, because the appropriate dose is that the dose which relieve pain without major side effect. And then there is no evidence to demonstrate the superiority of one opioid over another in terms of analgesic efficacy. We go to the various strong opioids available to us. The oral morphine, I think everybody knows about oral morphine and aware of oral morphine. It always remains a first-line therapy for moderate to severe cancer pain. And then the effective daily dose range from 25 to 2,000 milligrams, with the average between 100 to 250 milligrams. But usually in our experience, most of our cases is the dose, either 5 milligrams per hourly or 10 milligrams per hourly. It's really, we require a doses that are higher than that. In our practice, morphine is available as an immediate release, the syrup morphine, and then also available as a modified release preparation, is known as a morphine sulfate tablet or MS-1T. So all of these are available in the government books. Then the recommended dose is a 5 milligram per hourly of immediate release oral morphine in opioid naive patients. So the patients who are never received opioid before, but in the patients already non-opioid naive, 10 milligram per hourly has been shown to be safe and effective as a starting dose. Oxycodone also available. The modified release oxycodone has been available in the Asian market for quite some time. It's available in the forms of 10 milligram preparation and also 20 milligram preparation. But at the end of last year, the Oxynol, which is the immediate release oxycodone, is come into the Malaysian market. So available listed in the government books right now. And both modified release and immediate release oxycodone are as effective as oral morphine. And then if you use the modified release oxycodone, the onset of analgesia is about 1 hour of injection, and the analgesic duration is about 12 hours. It's a BD dose. Fentanyl, on the other hand, is a semi-synthetic opioid. It has a high lipid solubility but poor bioavailability. For this reason, fentanyl is not available in oral forms. It is for the chronic cancer pain management. It's available mainly in the form of transdermal metric patch. And then it is an effective alternative to oral morphine in a patient with difficulty in swallowing, because it's just a patch on the skin that is in the patient who cannot take orally, that at the advantage, or in the patient with intractable nausea and vomiting. However, all the guidelines require that to use the fentanyl patch. One of the conditions of opioid requirement are stable. So we need to aware also the certain opioid which require special attention. Number one is amphetamine. So in most of the clinical practice guidelines, including our Malaysian clinical practice guideline, the amphetamine should not be used for chronic cancer pain management, because its metabolite, non-pharmacological, may accumulate and cause the convulsion in the long-term use or in a high dose. The risk is higher in the elderly and patient with renal impairment. So the other opioid which is commonly used to us is the Adjuvant, it's a nalbuphine. The peculiar thing about nalbuphine is the nalbuphine is not the pure mu receptor agonist. If you remember in our pharmacology day, is to get the analgesic property from opioid, we need to stimulate the mu receptor. But the nalbuphine is rather agonist and antagonist type of opioid. Therefore, it should not be used in patients with cancer pain who already receive the pure opioid agonist. Morphine, oxycodone, fentanyl is a pure mu receptor agonist. So therefore, if we use Nuvane on top of it, it may reverse analgesic property of the pure mu receptor agonist, or even may precipitate withdrawal reaction when we give it together with the pure opioid receptor agonist. Practically, when you want to initiate opioid, then you start with opioid titration. After that is when we reach the lowest dose that we have the adequate analgesic with a reasonable side effect, then we maintain the opioid, and also we need to cater for breakthrough doses. So the current practice is to use immediate release syrup morphine, 5 mg for hourly as a initial titration dose. But in the patient who are elderly, renal and liver impaired patient, 6 hourly spaced up dosing is appropriate to cater for the delayed interference of the drug. Alternatively, now with the availability of oxycodone, we can use oxynone as a titrating agent. Once we have reached the suitable dosage, then we maintain. Either we want to maintain with the 4 hourly syrup morphine, or we can convert it to the modified release preparation, which gives us about 12 hourly preparation. No need to use so frequently 4 hourly. And then we need to give them also the breakthrough doses, usually between 15% of the total daily dose. Then sometimes we need to change the opioid for some other reason. Therefore, the changing from one opioid with another in order to improve balance between analgesic therapy and side effect is called opioid rotation. And then about 34.5% of the patients admitted to acute palliative care require opioid rotation. Therefore, when we assess systematic review of 31 studies, it shows that the opioid rotation able to improve the pain control over more than 50% of patients. Then the common indication that require opioid rotation is either adequate pain relief with that type of opioid, or due to intolerable side effect. And there is also because of renal impairment, and sometimes a practical consideration. Patient prefer some type of opioid rather than the other type of opioid. The patient cannot swallow, so therefore we rotate to another type of opioid. So this is when we rotate the opioid from one opioid to another opioid, it needs to be guided with the equi-analgesic conversion table. So this is the equi-analgesic conversion table suggested by our clinical practice guideline. So for example, if we look here, if we want to convert from oral morphine to oxycodone, for example. Then, when we titrate the patient, we got the total daily dose of oral morphine. The other thing we need to consider is the incomplete cross tolerance. For example, particularly if you want to rotate from morphine to oxycodone, we need to reduce the dose to cater for incomplete cross tolerance. The others does not require. So, for example, if the total patient requires 20 milligram of oral morphine for hourly dosing, it gives 120 milligram per day of the total daily dose. So we look at this oral morphine to oxycodone is, that means the conversion factor is divide. This color is in divide by factor 1.5. So when divide 1.5, so we got 80 milligram per day. Then we reduce due to incomplete cross tolerance, we reduce 25%. We got 60 milligram per day. Therefore, because of the frequency of oxycodone is BD dosing, divide by 2, we got 30 milligram twice a day. Then common side effect of all opioid is constipation. It's the most common side effect. Therefore, all the guidelines recommended, including our guideline, is that all patients receiving strong opioid, either morphine, oxycodone or fentanyl, should receive prophylactic laxative. When we look into the literature during preparation of the CPG, there is a few study looking into the different type of laxative. So among them is looking into the lactulose, the bisacodyl, and the Sinocot. Even though Sinocot is found to be superior than the others, even though Sinocot is quite cheap and available over the counter. Nausea and vomiting is another common side effect. Then, however, the good thing is usually is go off by itself after tolerance developed. Usually is after 5 to 10 days of opioid therapy. And for the meantime, you can use anti-emetic, for example, metoclopramide, haloperidol, propylperazine. Sedation frequently occur at initiation of opioid therapy, but mostly resolved within 5 days of opioid initiation. So the confusion and delirium can also occur, but usually mostly resolved within 1 to 2 weeks. However, when we deal with the patient with confusion and delirium, always we need to exclude the other underlying abnormality, for example, hypercalcemia, septicemia, or electrolyte. So in severe cases, we need sometimes a dose reduction by 25%, or we need to add the adjuvant analgesic. So respiratory depression is a rare event in a properly titrated opioid therapy, because sedation is always precedes respiratory depression. Therefore, when we initiate patient with opioid therapy, sedation monitoring is important to avoid the respiratory depression. So the pruritus and myoclonus is not that common, and pruritus can be managed by antihistamine, or we need to avoid that type of opioid and change it to other type of opioid. Myoclonus can be managed by pharmacological agent, for example, clonazepam. We need to know also about the adjuvant adjuvant drug for pain, which is the drug which is not actually the analgesic, but when given together with analgesic can be synergistically improve the efficacy of analgesia. Among the adjuvant analgesic use is the antidepressant or anticonvulsant, particularly in neuropathic pain. In our practice, we quite commonly the amitriptyline, or you can go for more expensive type, which is a gabapentin or pregabalin. The ketamine almost seldom used because of difficulty in monitoring patients. Biphosphonates also been proposed for basically for the pain as a result of the bone metastasis. However, when we assess in terms of evidence, the evidence is a conflicting. cost is quite expensive, especially the zolpidem, which is the one of the indication is pain due to the bone metastasis, particularly for the prostate. Corticosteroid commonly used as dexamethasone. This has a good property in terms of the pain adjuvant, particularly pain due to the pressure symptom as a result of the tumor compression. In cervical CA, basically, if you have the cervical CA with a liver metastasis, then what we have is the stretching of the capsule result in pain. So the corticosteroid may have symptoms of reduction of pain due to capsule distension. Then pain in the bowel obstruction, sometimes we can use the hyoscine, is buscopan. So other treatment modality assessed is radiotherapy, particularly to relieve pain in bone metastasis, either in the form of single fraction radiotherapy or multi-fraction radiotherapy. So radiotherapy remains a mainstay of the pain treatment as a result of bone metastasis, because it can release up to 80% of relieve the pain in up to 80% of cases. Psychosocial intervention have also positive effect on pain. Exercise basically is the fight against a disuse atrophy, but that's why in terms of in the literature is a positive effect, particularly in terms of extremities pain as a result of the disuse atrophy. So massage with or without aromatherapy also be shown to be has a positive effect. Acupuncture. Acupuncture is a lot of papers basically it shows that acupuncture has the effective for pain relief particularly from neuropathic pain. So some of the hospital has the complementary medicine services, particularly either in hospital Kepala Mata or even now in our hospital has the acupuncturist that giving the services for acupuncture. So some of our patients we do refer to them for to help in pain relief. So rare interventional technique, for example, neurologic sympathetic plexus phenomenon, opioid therapy can be used in difficult cases. This is our new cancer pain management. I'm sure that most of the hospital now receive this copy of management of cancer pain, our clinical practice guideline, which is started. The committee work started somewhere in 2009, and then the write-up was completed by end of last year, and the official launching was made in May this year, and then regional training has been made last year, but unfortunately it's towards the end of last year. Some of the states cannot send representatives due to the crowded financial problem at the end of the year. So now basically in the process of the training, where the training module has been produced, and then we will go all around the country to train people on the basics of the cancer pain management. Few words about tumor bleeding. It's not uncommon, and it can be life-threatening. The initial vagina packing with antifibrinolytic system can be used as initial measure. But however, the hemostatic radiotherapy is remain the treatment of choice. Tumor infection can lead to a foul-smelling vaginal discharge. We even have a patient who are very depressed because all the family members refuse to come home because of the home is smelly all around. So even when they come to the clinic, also they have to open all the window and then start calling the favor to spray all the way. So the vaginal packing with the charcoal, not the charcoal that we use for barbecue, but the charcoal which is the sterile charcoal we use for paraquat poisoning. Crush them, mix the metronidazole, which can absorb the smell and also reduce the control the infection. You can also adopt the metronidazole vaginal bleaching with systemic antibiotic. The obstructive uropathy can result from the very poor tumor spread. And early urethral stenting may be useful in preventing total obstruction, which stenting because it's technically not visible at that time. And then tumor stent have added advantage in alleviating the needs of frequent change in stent, yearly compared to the 4 to 6 months they use normal DD stent. However, the tumor stent is more expensive. And then if a stenting is not feasible, probably we do need a nephrostomy to salvage the kidney. Lymphoedema may result in a lymphatic obstruction due to tumor infiltration into the lymphatic system of the pelvis. Sometimes we do need to do the lower limb Doppler ultrasound to exclude venous thrombosis. And then conservative management remains the mainstay. We can use a lymphatic massage, even when I met the bleed, which is a chief of the physiotherapy in HKL. Quite a number of physiotherapists is trained in lymphatic massage for lymphedema. So we can refer to them, or we can ask them to elevate the leg university, or can refer them to occupational therapy for compression garment. Diuretic may be used on a clinical basis. And then we have to look at the early detection in terms of possible complications, particularly cellulitis and other infection. Surgical modality to treat lymphedema is very required. Venous, a few words about the second last slide is the venous thromboembolism. The high viscosity in cancer combined with pelvic disease and also together with immobilization make the patient higher risk for venous thromboembolism. Treatment no different with other form of VTE, and basically in acute phase and maintenance phase. Acute phase, traditionally we use unfractionated heparin infusion, and currently the low molecular heparin can also be used as in the acute phase treatment. In our practice, basically we prefer to use low molecular heparin rather than unfractionated heparin due to the more easy to monitor. You don't require to prick the patient every 6 hours to measure the APTT. The low molecular heparin, the problem with low molecular heparin is the cost. So what we have now is in our practice, we use fondaparinux, which is an extra for a Muslim patient, because the fondaparinux is the only low molecular heparin is not pulsar based. Then we use either vaccines or tinzaparin for the non-Muslim. So the newer low molecular heparin been registered in the blue book is the tinzaparin. The advantage of it is much cheaper. So for Klexin and fondaparinux, the government cost price about 20 ringgit per shrink, which is converted into the treatment cost of 40 ringgit per day. And the tinzaparin is much cheaper, which is about 8 ringgit per day. For maintenance phase, we can use warfarin, so low molecular heparin. We usually use warfarin because of cost concern. And the duration of treatment will be about 4 to 6 months, but in some patients it may require lifelong treatment. So with that, thank you very much.